These are must remember points of diabetes. First of all, we are aware that type 1 diabetes is an autoimmune disease. Why? Because there is an autoimmune destruction of the beta cell of the pancreas. And the question that is asked whether it is a B cell mediated or a T cell mediated. It is a T cell mediated disorder. Second question is what are the antibodies? Antibodies are islet associated antigen antibodies and glutamic acid decarboxylase antibodies. These two questions are very important and they are repeatedly asked in MRCP exam. Next thing is that the identical twins show a genetic concordance about 40%, while as in type 2 diabetes mellitus, there is 100% concordance in identical twins. In type 1 diabetes mellitus, there is HLA-DR4 and DR3 association, while as in type 2 diabetes mellitus, there is no HLA association. So in type 1 diabetes mellitus, there is absolute deficiency of insulin. So there is no synthesis of insulin from the beta cell of the pancreas. So the treatment is always insulin. Treatment is always insulin. While as in type 2 diabetes mellitus, there is a defect in the receptor. So there is increased resistance of the insulin. So we have to increase the sensitivity of the receptors, and increased sensitivity of the receptor is done by various drugs that are used for the treatment of type 2 diabetes mellitus that will we see as we move forward. So, and the important point is that we should be aware about the normal glycated hemoglobin values and what are glycated hemoglobin values in pre-diabetic and in diabetic patients. Normal is less than 5.7, and you have to remember the value that is seen in diabetic patient, and it is more than 6.5. It is always more than 6.5. It is a diagnostic criteria also. So the diagnostic criteria of diabetes mellitus is fasting blood sugar should be more than or equal to 7 millimole, or in mg per deciliter it is about 125 mg per deciliter. Random blood sugar should be more or equal to 11.1 or 200 milligram per deciliter, and same the random blood sugar and 2 hours after 75 gram OGTT is about 11 more or equal to 11.1 millimole per liter. And the important is HbA1c should be more or equal to 6.5 or 48 millimoles per liter. In case if the blood sugar value is about 6.1 to 7 millimoles, like we know the fasting should be more or equal to 7 millimoles, and the random blood sugar should be more or equal to 11.1. But in case if the blood sugar is less than 7, it is impaired fasting glucose. And the question is asked why it occurs. It occurs due to hepatic insulin resistance. It occurs due to hepatic insulin resistance. And what in case if the blood sugar level is about 7.8 to 11 millimoles per liter? It is impaired glucose tolerance, and impaired glucose tolerance is due to muscle insulin resistance, and the treatment of both these is lifestyle modification. We don't have to give any drugs or neither insulin. It is always lifestyle modification for these two conditions. The important note to be noted is that triglyceride is the strongest independent predictor of the cardiovascular death in patients with impaired glucose tolerance. The triglyceride is the strongest independent predictor of the cardiovascular death in patients with impaired glucose tolerance. And the level of HbA1c is dependent on RBC lifespan. We all know the lifespan of the RBC is about 120 days, that is around 4 months. So the HbA1c gives a prediction about the control of the diabetes for around last 4 months. So in case the HbA1c is lower than the expected, it is an important question that is repeatedly asked in MRCP. If the HbA1c is lower than the expected, you expect that patient should have HbA1c of this value, but it seems to come very low. Differential diagnosis should be kept in mind. The mainly autoimmune hemolytic anemias like sickle cell anemia, G6PD deficiency, and hereditary spherocytosis. Also in chronic liver disease, as there is decreased erythropoietin level, splenomegaly, and hypertriglyceridemia. When the HbA1c is lower than the expected, it is due to premature destruction of the RBC. So the RBC lifespan is reduced, as well as the HbA1c will remain low. Same as in HbA1c is higher than the expected due to increased RBC lifespan. It is due to iron deficiency anemia, vitamin B12, folic acid deficiency, as well as in alcohol dependence, chronic renal failure. Please remember, it is here chronic liver disease, it is chronic renal failure. Also, here it is splenomegaly, and here it is splenectomy, and here it is hypertriglyceridemia, and here it is hyperbilirubinemia. So HbA1c reflects blood glucose over previous 2 to 3 months. We should know about the management of type 2 diabetes mellitus according to NICE guidelines. So first thing is, if any patient comes to you with an HbA1c or a blood sugar level more as of the diagnostic criteria, we read about it. So the blood glucose levels are in the range of diabetes, and to diagnose the case as diabetes patient, so the first thing is you should always start with the lifestyle modification, and you should give him advices about the weight management and exercise and all, because they increases the insulin sensitivity. And second, if after the exercise you check his or her HbA1c levels and it came to be out of the normal value, and it seems to be uncontrolled, then you should add a metformin drug. Metformin is always used as first line drug for the diabetes, and it is also used along with other drugs also. Metformin is also used along with the insulin. No other drug is used with the insulin except for the metformin. So metformin is a very important drug, and it is the basic initiator of the treatment of diabetes. So after metformin, if you check the patient's HbA1c after 3 to 4 months, you see that the HbA1c is still high, then you increase the dose of metformin. Like the patient was taken 2 times in a day, you increase it to 3 times a day. Okay, now after the metformin 2 doses, the patient has still the uncontrolled diabetes mellitus, then you have to add the second line drug like sulfonylureas or any other drugs from the list of the treatment of diabetes. In case the patient's HbA1c remains till the range of 51 millimole or 6.8, then you should keep in mind to increase the dose of the metformin. And in case if it is more than that, if it is more than 7.5, then the second line drug should be added.